Post-best CLI, Basel II and Revive, controversy solved. Of course, I would not be standing here if this controversy is solved. But it's first of all very important for me to understand how many are interventional cardiologists and how many are vascular surgeons. Let's start with cardiologists. Okay, good number. Vascular surgeons, also good number. Interventional radiologists. Okay, good. We have a good mix. Perfect. Okay, so we'll dive through this together. When we look at the evolution of revascularization strategies for atherosclerotic disease, we start with coronary artery disease, bypass versus PCI. You see a plethora of randomized clinical trials with strong evidence, large-scale trials, and now we have actually a good pathway to decide which patient gets bypass and which patient gets PCI. When we come to the peripheral world, we find a lot of trials, but most of them, I marked only the three bigger trials with a meaningful number of patients to draw conclusions in red, and this is Basel I, Basel II, and BEST CLI. All other trials are of smaller sample size and were triggered for primary patency as an endpoint and not mortality or amputation-free survival. So when we have to make a decision for our patients for revascularization strategy, we have only actually in reality 4 studies, 3 of them for critical limb ischemia, Basel, BEST CLI, and Basel II. And for a predominantly claudicant population, I'm going to talk about this a little bit later, is the Revive study, is a pooled analysis of patient-level data. So everyone saw this already multiple times, presented at AHA as late-breaking trial, published in NEJM. Landmark trial, BEST CLI, cohort 1, GSV bypass graft is superior to endovascular therapy, and cohort 2, prosthetic graft is equal to endovascular therapy. And this is the graphs as we have been shown to you. The main driver of this trial was major reinterventions, which was in favor of bypass surgery, and to a smaller extent, but still significant, also the amputation in the bypass arm. When we look at the subgroups, in cohort 1 of BEST CLI, we see that Rutherford class 4 fares very well with a GSV graft. But when we look at race, for example, African Americans or other races, we see them that their outcomes are not as good as for white patients, means that there is a little bit of racial distribution of the outcomes with GSV. Age, patients who are above 80 have a worse outcome, or actually not the same favorable outcome with a GSV as younger patients, and similarly also patients with chronic kidney disease. When we look at the next trial, this is the Basel II, we see that the outcomes after 3 years of follow-up, or a little bit more than 3 years, major amputation-free survival and overall survival was in favor of endovascular therapy. Now you're going to say, wait a second, I have 2 trials which show exactly the opposite outcome. In reality, they are not showing the opposite outcome. It's just a little bit different patient population, and we have to go through this very busy slide to understand what the differences are. Both trials were independent of industry, which means that they were funded by national institutions, NIH in America, NHS in UK. Patient population were both trials Rutherford class 4 to 6, so critical limb ischemia patients. And in BEST CLI, infrainguinal plus minus infrapopliteal disease was allowed in the trial, while in BEST CLI, you must have had an infrapopliteal lesion to be enrolled in the study, which means this is a little bit more advanced patient disease population. Eligibility for enrollment, you must have been eligible for bypass or surgery according to the treating physicians. And in BEST CLI, a life expectancy of at least 2 years was mandated to be enrolled, and in Basel II, only 6 months, which tells you that this is a little bit advanced disease or sicker patient population. And this is also very important now. Trial design, this is a little bit confusing for many people, but to me, if you look at both trials, the bypass surgery was predefined very well in BEST CLI by the presence or absence of a GSV. You have a good GSV, you get into cohort 1, which is predefined. And you don't have a good GSV, you land in cohort 2 with a prosthetic graft. Similarly, in Basel II, you must have had a good GSV to begin with to be enrolled in this trial. However, when we look at the endovascular arm in both trials, it was decided on the day of the procedure at the discretion of the treating physician. And you can now imagine how much it opens for a plethora of of variety of devices, procedure types, access types, and crossing types for these patients. When we look at the enrollment yield, both trials ran almost for 10 years or a little bit longer, and out of all the patients screened, only 10% roughly were enrolled in these trials. The primary endpoint of Best CLI was a new endpoint, which was not used before in this arena of research, which makes it hard to compare this data with any previous trial. On the other side, Basel II used the well-known amputation-free survival, which is a very pragmatic endpoint, but very solid to assess long-term outcomes for patients with CLTI. Median follow-up was 2.7 years in Best CLI, 3.3 years in Basel II. The operators for Best CLI were predominantly surgeons, but interventional cardiologists and radiologists were also part of the trial. In Basel II, vascular surgery and interventional radiology dominated this trial, and interventional cardiology was not part of the trial. The major drivers of the outcome in Best CLI was major reintervention, and to a little bit extent amputation, and for Basel II was all-cause mortality. And very important, the last two lines actually, mortality rates were very high in both trials, and the trials ran into COVID and had a few issues with that. So the investigators of Best CLI looked at their population and said, how about we look at the outcomes if we take our patients who would be also fitting into Basel II and do the analysis again. And they did that, and they found that amputation and survival is comparable between bypass and endo. However, due to the higher rate of reinterventions, bypass won again for the outcome major adverse limb events. We thought, how about if we make the comparison a little bit more fair and say, we want to predefine endovascular therapy to begin with. And we said, how about a scaffold to say this is preemptively defined for endovascular? As compared to bypass surgery with a prosthetic graft or a vein graft. And we found in the literature 6 randomized trials fulfilling this criteria. We contacted all principal investigators, and we got 5 of them to donate us their data. And we did a patient-level pooled analysis, and we tried to be similar to Best CLI and to Basel II. So this is the primary endpoint, major adverse limb events after 2 years. Scaffolding as endovascular therapy with scaffolding is comparable to bypass graft surgery with a GSV graft or a prosthetic graft. And we tried to be similar also to Basel II, and amputation-free survival were comparable between those 2 groups after 2 years. When we look at the subgroups, and this is predominantly intermittent claudicant population, but 1/3 were critical limb ischemia or acute limb ischemia actually as well, you see that the confidence intervals and the hazard ratios are almost overlapping, means that the therapy, both therapies fare equally well for the primary endpoint major adverse limb events. So if you ask me my approach for the revascularization strategy, it starts always with presentation. Claudicants, our guidelines prefer endovascular therapy over bypass. For CLTI, if you have a Rutherford class 4, bypass would probably do better with a GSV. The anatomical complexity is important. Do you have only infrainguinal disease or with infrapopliteal disease and no good distal target, which means that you cannot insert a bypass very well, and this would push you towards endovascular therapy. The next is surgical risk assessment. Is your patient fit for surgery as a high-risk procedure, as a vascular bypass surgery? Those patients would fare better probably with endovascular rather than bypass. Is a GSV available, and is it suitable for use? Those patients I would think more about bypass surgery than endovascular therapy. And patient presentation urgency and location of the patient. Do you work in an urban area where you have vascular surgery on site to assess the patient and offer a meaningful revascularization on time with bypass, or do you have to ship your patient for hours, cross counties, to get this therapy done? And finally, also our patients are very vocal nowadays, and they go to ChatGPT and other AI tools, and they ask you, Best CLI says I should get a bypass. Why are you offering me endo? So you have to be ready to answer those questions and then make your decision with the patient. If you apply this algorithm, you're going to find yourself at the end enrolling only 10 to 20% of your patients into bypass surgery, and the remaining will need endovascular therapy, which means that you have to be actually really good at it and learn it and stay on top and offer it to the majority of your patients. Finally, very important to me, even though I'm extending a little bit beyond my time, when we look at Basel I, Best CLI, and Basel II, we have 20 years lag between those trials, and the mortality is still the same. Means that we are revascularizing, we're bringing new devices on the market, but we are not treating actually the real problem, which is the patient who is being neglected for years and years and years. And we are missing those patients to treat them aggressively early on and offer revascularization on a timely fashion. When we look at data published from national sites, we see that guideline-directed medical therapy in PAD is severely neglected in comparison to CAD patients, and both are atherosclerotic disease patients. And finally, the role of exercise therapy, at least in the United States, it's not well defined because it's reimbursed, but payers and health systems are not pitching in to offer this therapy on a wide scale to be able to see what outcome is associated with a prolonged exercise therapy. It would be great to see if it can reduce the progression from claudican to CLTI. It would be great to know whether it has an impact on long-term mortality and on limb loss. Thank you very much. If you have any questions, reach out to me at any time.